Good afternoon, everyone. You're very welcome to today's tipsRO webinar. My name is Michelle Leech, and I am Professor in Radiation Therapy at Trinity College in Dublin in Ireland, and I'm also Editor-in-Chief of tipsRO, and I will be moderating today's discussion. So we understand there's been some technical issues about people getting into the webinar, so I hope that you'll be able to watch this recording afterwards in lieu of that, and our sincere apologies for that problem. But I'm delighted today to introduce you to two excellent speakers who are speaking to our topic about advanced radiation therapy practice, which of course is extremely important in all global regions of the world. So let me firstly introduce you to Robbie Beckert. And Robbie is the advanced practice radiation therapist at Washington University School of Medicine in St. Louis, USA, and specializes in organs at risk contouring for online adaptive radiation therapy. And in addition to his on-machine art contouring duties, Robbie is also heavily involved in adaptive research and data collection, as well as in advanced practice research overall, with an overarching goal of creating a new career pathway for radiation therapists within the adaptive space, which is so important. He received his certification in radiation therapy from Washburn University in Topeka, Kansas, following a Bachelor of Science degree in Radiologic Science in 2014. And he has worked as a radiation therapist for 8 years, with 4 of those years working in CT and MR-based adaptive platforms before he became an APRT in 2022. And Robbie's a very experienced APRT, and we're delighted that he's going to be speaking to us today about the impact of an advanced practice radiation therapist contouring for a CBCT-based adaptive radiotherapy program. But before we get to Robbie, I'm also going to introduce you to Dr. Yatman Sang, who is an associate professor in the Department of Radiation Oncology at the University of Toronto in Canada. So we're not European today at all. I'm outnumbered. And he serves as the Director of Radiation Therapy of Radiation Medicine Program at Princess Margaret Cancer Centre in Toronto. And Yat's research interests focus on radiotherapy trial quality assurance, ultra-hyperfractionated or stereotactic radiotherapy treatment outcomes, and strategies to future-proof radiation therapist practice, which of course involves advanced practice. So you're both very welcome. Thank you for joining me today. So Robbie, I'm going to ask you to share your screen now, if that's okay, please.
Of course.
Thank you. And we'll just check that that's all coming through. Lovely. Yeah. That looks perfect. Okay, so I'm going to switch off my camera and hand over to you, Robbie, and look forward to hearing your presentation. Thank you.
Thank you. Well, like she said, hi everyone, my name is Robbie Beckert. Thank you for being here. Today I'm going to be talking about how an advanced practice radiation therapist improves contouring time for online adaptive radiotherapy. At WashU, we have a very robust adaptive program, treating over 250 patients adaptively each year. And this is because we were one of the first in the world to have a dual modality adaptive radiotherapy clinics. The only problem is that art is a resource and time-intensive process. It requires staff to be at the machine for extended periods of time, and this includes therapists, physicists, and physicians. So we decided to create an advanced practice radiation therapist position that specialized in art contouring. And according to tipsRO, the Radiation Therapy Committee, an advanced practitioner works outside their scope of practice and demonstrates expert practice in a specialized area. Currently, there's only 2 APRTs in the United States and only 1 doing art contouring. So we hypothesized that if we task shift art contouring from a physician to an APRT, we would notice improvements in contouring times and treatment times, while also reducing the time burden of art on our physicians. So this study looked at contouring times for online art with and without an APRT. To quickly go over our methods, all of these patients were treated adaptively on eFlows on the adaptive platform. The manuscript reports timing data that was collected over a 9-month period, and then we continued to collect timing data for another 4 months. Over this 13-month period, we treated 61 patients and reviewed over 300 adaptive sessions. 59 of those patients were adaptive SBRT cases receiving 5 fractions or less, and 2 were adaptive IMRT cases, receiving 20 fractions each. In the study, we analyzed 1 APRT and 7 different physicians and looked at the time it took to contour, the time from initial scan to verification scan, which we call this the adaptive process, and then reviewed the total time for treatment. Here's a breakdown of the first 9 months, with 47 cases being done by the non-APRT and 136 cases being done by the APRT. And here are the cases 4 months after that. As you can see, the caseloads are still proportional to each other, but it also shows that there was a spike in the amount of treatments that we were able to get onto the machine. The workflow for both groups were the exact same. The main difference was when the physician got paged for the case. For non-APRT fractions, the physician was paged before the initial scan was acquired. That way, when they would arrive, they could immediately start aligning the target and contouring the OARs. For APRT fractions, physicians were paged once the targets had been aligned and the contours were completed. That way, the physician only had to review and approve alignment and contours or make any changes that they deemed necessary. For consistency purposes, timing data was recorded at the start of each task and stopped when the task was completed. And as a side note for this, every adaptive case must have the alignment and contours approved by a physician before proceeding to plan calculation. When we looked at the data collectively, the APRT provided a significant decrease in the time it took to contour, which was 9 minutes compared to 23. The same effect on the total treatment time was not seen in the overall evaluation. We determined that the problem with looking at the statistics collectively was that there was a high variability in the cases that we treated across multiple disease sites. For example, a pancreas SBRT case takes at least 45 minutes and typically over an hour. Those cases were evaluated alongside hyperfractionated bladder treatments that were completed on average within 30 minutes per the trial protocol. This variation can mask improvements in total treatment times among the entire population. This meant that we had to look at the data a little differently, and I would like to show you 2 different ways to see this, and the first is with numbers. So from October 22 to July of 23, we did 183 adaptive treatment sessions with 36 patients being studied. 17 of those 36 had APRT fractions only. That means all of the contours were completed by the APRT and not by a physician. The remaining 19 patients had at least 1 APRT fraction and 1 non-APRT fraction. And then for that last 4 months, we ended up totaling throughout the entire process 303 adaptive sessions, 61 patients, and 25 of those patients had APRT fractions only, and the remaining 36 had at least 1 APRT fraction and 1 non-APRT fraction. The second way I want to show this is visually, so you can see what this comparison looked like. So of those 61 patients, like I said, 25 had APRT fractions only. The remaining 36 had at least 1 APRT and 1 non-APRT, and this allowed for an inter-patient analysis. And this is where we looked at each patient individually, and the fractions contoured by each group were then averaged separately. Then those 2 average times were compared to each other for that same patient. This showed that the APRT still provided a significant decrease in contouring, but also found that the total treatment time was reduced significantly as well. But we still didn't see a change in the adaptive process. For this, we wanted to look at the calculation time. On average, it took the physician 5 minutes to come from where they were at over to the machine to review contours and alignment. After they did all of their work, which ended up only being 4 minutes for the APRT fractions, there was a 7-minute average calculation. In that time, instead of staying at the machine, some of those physicians would go and start approving images, or they would see an on-treatment visit, and then they would come back. So that meant that transition time, instead of 5 minutes, could have actually totaled a total transition time of 10 because they left twice. But that's the advantage because they would have more time to do so. By having an APRT contour, the time requirement for a physician went from 23 minutes to 4 minutes. And that's a time savings of about 19 minutes per case. And on the days that we're treating 5 to 6 adaptive cases, SBRT adaptive cases, a physician could save over an hour and a half of time each day. There are clinically proven benefits for the use of adaptive therapy throughout the body. But right now, it is too resource and time intensive to treat every patient adaptively. We need to decrease the amount of time that a physician is at the machine, but the hard part is that in the United States, there are requirements for SBRT coverage and the MD must sign off on all new plans to meet billing requirements. It's important to note the goal of an APRT is not to replace a physician, but to assist them. Task shifting the tedious and time-consuming aspects of ART to an APRT can alleviate additional workloads put on the physician, provide physicians more time to conduct work that only they can do, while still meeting billing requirements and still delivering the same quality adaptive treatment. In conclusion, we successfully implemented an APRT specialized in online adaptive contouring. The data presented shows statistical improvements in contouring time and total treatment time, which suggests that an APRT specifically trained to manage ART contouring can reduce physician workload and patient treatment time.
Thank you very much, Robbie. That's a really interesting presentation. Thanks so much for that. I hope you don't mind if I ask you. I'm, of course, taking notes and I have several questions, and Yat may have a couple too. I was just wondering about, and of course, you know, people listening to this webinar, we're all coming from very different, you know, backgrounds of, you know, health provision and healthcare. So I know you made the point about billing, because obviously it's a probably quite a different system in the US than it is, say, for us here in Europe. But I was wondering if you did any kind of or would you think of in the future doing any kind of health economics or cost saving analysis? I know you've done the time saving and you've presented that, but I would imagine a 1.5 to 2 hours of a radiation oncologist time saved is actually quite a large cost saving to the, you know, to the department. Or have you any comments on that, or maybe we could understand that system a little bit more?
We actually are in the process currently of doing a time-based activity cost analysis to see the breakdown of what it would cost for multiple different coverage scenarios, evaluating therapist, advanced practice, a mid-level provider, and then the physicians. Yeah, so I think that would be very beneficial, you know, particularly for, you know, those of us who are trying to start out in advanced practice, to show, you know, obviously the bottom line's not the main incentive, but sometimes, of course, for governments it is. So, you know, having those data would be really helpful. I was wondering what kind of advice you would give someone. So say, for example, if I was starting out doing this contouring as an advanced practice RT, I mean, did you have a specialized delineation training program along with your other education? And what site, just looking at your time saving, I was kind of thinking you probably would start at pelvis maybe, or what would your advice be about that? For training, it was kind of one of those scenarios where it was a last man standing, and I kind of got roped into trying to be as helpful as possible, because I could see how much of a problem it was on machine for the physicians. And little did I know that I was slowly being groomed to do that position. So I kind of had a lot of on-the-job training with a lot of physician feedback, but I was constant paying attention to each case and asking questions. And that ended up being close to a year of just strictly on machine, which is not feasible for everyone. So after we did that, we ended up getting hired. I got hired into this position, and then I had a very strict, dedicated, you contour everything for the anatomy and kind of go all the way through and run through those contours with a physician and get step-by-step feedback, and then also continue to figure out where those pain points were and what issues that I needed to fix, because obviously you can contour anything offline, but when it comes to online adaptive, efficiency is key, and being able to recognize structures accurately and efficiently and problem solve on the fly is different. So you do need that specialized training, and it's something that I don't think therapists should just start with. I think it's something that needs that specialized training, and with that comes more risk, more liability, but also more responsibility and more compensation, because you are doing something that's not the norm.
Yeah. So you're quite well placed now to put a training program together for people who will be coming after you. I'm just thinking as you're saying that.
And we are currently in the process of trying to figure that one out as well.
Yeah.
And then to your second question about site, usually pelvis is the easiest and quickest, but knowing that there's obviously adaptive cases throughout the body, and as you saw in that picture, we're able to treat almost every place in the body adaptively. It's just getting that to be to the point where all of your resources are in line to be able to do something like that. But starting out something easy like a pelvis is probably the best case, and then slowly working your way up, but knowing that at some point you're going to have to be able to contour everything.
Yeah, thank you. Yash, you want to come in there, please?
Thanks, Michelle, and thanks, Robbie, for the great presentations. And actually, my question is actually following along and what the discussion between you and Michelle. And so, Robbie, I think the model you proposed for the APRT, which is great, and which I think is thanks for sharing the success story. But when you're doing so well, and with the kind of the skills that they acquired to really streamline the processes, eventually, Robbie, with the model you present is a one-man band. So I just want to ask about, what would be your service continuity plan, when, for example, when the APRT is not available, or when the APRT is actually, go on a farewell to certifications, what's going to happen to your services?
We have a lot of grumpy physicians that have to then do the work. But it's also, that's how we were able to get timing data, by having specific days that I had off, or for vacation, or for sick days. Ultimately, it's not sustainable to only have one, especially when you're treating that many cases a year. And then we also have 2 adaptive, an MR and CT base, and then we just did a month ago, the first online proton adaptive. So that's the case. One APRT cannot handle that workload. So trying to figure out what the next step is and how to train the next person and what that looks like is a work in process. But the goal is hopefully to expand that to other places to show the success that we're having, and that we're able, in those 4 months after we did 9 months of work, really shows that we were able to then increase our workload because we had such a time savings instead of just being complacent with where we were at. So it's working. We just have to get other people to kind of see that, and then get administrations to understand that as not only a efficiency standpoint, cost standpoint, but from a safety standpoint as well.
Yeah. Very valid point. Well, I think you've certainly made the case and convinced us that you need more than one Robbie in your centre. It's really important work that you've done, and thank you very much for sharing it with us today. So
thanks for having me.
No problem. Yat, I might ask you to share your screen, please, if you don't mind. And Yat is now going to speak to us about RTT Advance practice and how it can change the future of radiotherapy. I love that title. So thank you, Yat. I'll hand over to you now.
Thank you, Michelle, and thank you. And first of all, thank you for the tipsRO and editorial board, and then also, for the editor-in-chief, Michelle Lynch, and giving me the opportunity to talk about, our recent publications in tipsRO. And my disclosure with no conflict of interest. So usually that, I just want to put a spotlight, on the paper that we want to talk about today. So as Michelle said, that, I didn't come up with the title. Actually, is, come from the brilliance from the writing panel that, come up with the title of RTT Advanced Practice and how it can change the future of radiation therapy. And so as you can see, from the paper that, the first author that actually is my beloved colleagues, Dr. Aileen Duffton. Unfortunately, Aileen could not be here today. So then that's why I take on the big task of presenting this paper on behalf of the whole writing panel with Nicole Harnett, Professor Helen McNair, and Eric Bennett, and Melanie Klassen, and Jose Guillermo Cotto, Kevin Lawyer, and Christy Matthews, Celeste Olivieri, and then Natalie Rosek and Rita Simons. So when we go on, I just would like to bring it back, and about a saying that I love a lot, about the past is a prologue, a story that sets the stage for your own. So I don't want to say that, we're going to tell about, a really long history of stories about where this paper coming from. But I think it'd be just good that, we kind of start the journey about, starting with the position paper that our ASTRO RTT committee that presented in 2019, which I'm very glad actually for the previous presenter, Robbie, actually used that paper as well. So the work that, being done by the colleagues that led by Aileen and actually being supervised by Michelle. I know Michelle going to tell me off. I've not got time to update her picture, but for my personal defense, I think she looked the same, no matter what she said. So with our 2019 ASTRO RTTC position paper on advanced practice, we give a definitions about advanced practitioner. They are the colleagues that work outside the scope of practice, and also they're able to demonstrate the expert practice in a specialized area. Also, they work autonomously, taking on a leadership role in the development of radiation therapy services and the research actually associated with the specialties. So then, in 2021, following the position paper that we've been very fortunate, tipsRO actually feature special sessions on advanced practice in radiation therapy. And then I got the kind of the honor to work with, I call her the Canadian Advanced Practice Radiation Therapy godmother, Nicole Harnett, to prepare the kind of special issues. So we've done an editorial looking at about how to move to the next level for advanced practice in radiotherapy. If the colleagues that you have not checked that special issue out, I would strongly recommend you to have a look at tipsRO. Actually, the special issue actually feature, I would say, worldwide examples for radiation therapists, advanced practice in disease site specialists, organ arrays and target volume delineations as kind of featured by the previous presenter, palliative radiation therapy, image-guided adaptive radiation therapy, and research domains as well. So with the 2021 special issues that, for our ASTRO RTT committee, that we did see the success and also about the interest from our community. So with that in mind, that, we actually run our second radiation therapist committee workshop. And then in that sense, that, in 2022, one of the theme of our RTT workshop that we kind of designated for advanced practice in radiation therapy. So I work with Nicole, Aileen, and Helen, being a faculty member to facilitate the workshops. So a bit of the timeline of the workshops that we have run in 2022. So we've done some pre-workshop preparations, to explain to the participants of the workshop of the aim, expected outcomes, and also give them some advanced practice radiation therapist resources that are available in the literature. On the 15th of November 2022, we run our part 1 of the workshop. There will be a 2 hours virtual workshop that with live discussions and comments. And then we have some in-depth discussions and collaborations between 2 subgroups within the part 1 workshop as well. After the workshop, the faculty members that, we look at the meeting recording, the chat discussions, and the polling results. And then we then run our part 2 of the workshop, and then that is in 2023. And then we have a panel discussion, and then we've done further pooling and data capture. And after that, we try to form our writing panel and then try to look at the findings from the part 1 and part 2 of the workshops. And the position paper has been drafted, and then also with our kind of the reference group. And then voila, that come with this paper in 2024, and it been published on the kind of, I would say, the second wave of the position paper from our RT committees on how we can use advanced practice in radiation therapists to change the future of radiation therapy. So if we're going to go through the kind of the results from the different parts, if we start with the part 1 of the workshops. So from our discussions that we try to look at with the participants, look at the descriptions of advanced practice radiation therapy. So we come with 4 themes, and first theme is about the clinical expertise, and the keyword that, from that theme that, come up with autonomy, specializations, and competency. The next theme is looking about the decision making, and the keywords relate to that themes about critical thinking, complex decision making, and problem solver. The third theme from the discussions about leadership is about influencing, innovative leadership, and being an agent of positive change. The last but not the least is the innovation themes is about being resourceful, multidisciplinary, proactive, and continuous. With that, for the part 1 of a workshop, we're looking about, how can we do standardizations in advanced practice radiation therapy. So for the first graph that we're looking about, about the aspects that need to be standardized. So for this graph that, we come up with kind of 5 aspects, and they are levels of practice, educations, level of autonomy, competencies, and then career prescriptions. So you can see that, for the kind of the aspect of standardizations, and the need for that, to come with the top is about to be standardized in level of practice, and then come along with educations and level autonomy. And with this graph, if I can get the audience to focus on is about the competencies, actually, I would say there's the least agreement about the urgency for that aspect to be standardized. Then we go into the next graph, look at about how easy for the aspect to be standardized, for the 5 aspects that we just discussed. So for that, you can see that, the easiest one actually being discussed and agree on is about the education component. And second, actually, is the competencies bit. So we can see that, and actually our discussions that, come in about maybe the competencies that we have the kind of the least urgency to be standardized, but at the same time, we come with the kind of the ease of doing that. And the difficulties piece, for the discussions on about the area to be standardized, mostly about how we're able to career progress our colleagues who are in the APRT roles. So with the part 1 workshop finished, for the part 2, we're looking about the possible concerns and issues raised when we want to progress the APRT concept in the global settings. So the themes that we look at in the part 2 of workshops about the role definitions. So and the issues that we come up with about, how can we able to standardize the APRT roles, and hopefully for the audience we can all agree that the relevance of that theme is about how we can establish clear and well-defined roles for APRT, and also about this clarity will be a crucial step for us to advancing our professions and also ensure the APRT roles are understood and recognized. The next themes we discussed about the training and educations, the relevance of that themes about, how important for us to address the issues related to training and educations. This includes about how we're able to standardize the education requirements and recognizing the different levels of APRT existing in the global settings. Hopefully, we're able to demonstrate the ways to developing these roles and providing guidance to the employers and colleagues who are in these roles. The third themes that we discussed is about the funding challenges and also about the regulations. So how relevant is these themes is about, how we're able to display the identifications of the solutions to the barriers and how can we explore the future roles within APRT. So they involve about how we're able to consider needs and aspirations of different stakeholders within the healthcare services. The last themes that we discussed is about the successions and career development. I think this theme that, actually address about the importance of APRT succession planning. So we're able to highlight the need to address the APRT career progressions within a standardized framework. We actually recommend that research should be significantly embedded in the APRT roles, so we're able to have a focus on its integrations, disseminations, collaborations, and the impact on patient care and service improvement. With that, for the kind of final part of our part 2 workshop, we'll look at the enablers for progressing APRT in healthcare services. So using the 4 themes that we discussed before, for the role definitions, the recommendations that we say for the enabler is about we need to establish the consensus of APRT definitions and practice level. We need to advocate for clarity and value of APRT within the professions. We need to develop standardized guidelines and frameworks for APRT. For training and educations, we need to integrate research into APRT roles focused on patient care. Our APRT colleagues need to promote innovations, educations, and collaborations between themselves. For the regulations and funding challenges, we need to try to ensure that we have adequate funding, governance, and support for APRT integrations. Advocacy for proactive planning and evidence-based practice to push APRT forward. The succession and career development, we need to support a wider organizational recognitions and workforce planning for APRT. Integrate APRT into service design and establish clear expectations. We need to emphasize research, precision medicine, and patient care in APRT development. So come to the last part of our presentations about some take-home messages. And I think from our second position paper, that as an output from our workshop, we still see uncertainty in effectively operating APRT within the healthcare services, where we try to remain agile to changing the practice landscape. We need to standardize the role definitions, education frameworks, and then also about the regulations and career development pathways, so we can using that to enable the advancement of APRT. We need to recognize our APRT colleagues, their trial basis, and they need our support. A culture shift can enable APRT to reach their full potentials. And I just want to bring the last part of my presentations to the awareness of our APRT international community of practice, that actually represent a very positive step with a lot of research collaboration opportunities being facilitated through this group. So the last, I would like to acknowledge all the workshop participants for their contributions, and also about the writing panel for their help and support for pushing the position paper into finish line. That's the end of my presentations. Thank you very much.
Thank you very much, Yat. That's it's always good to see the end product from a workshop actually in print and presented like that. And you clearly had very interesting discussions during that workshop. I was busy in another workshop, so
I know, Michelle,
which was also interesting. So it's quite nice to, obviously, having read the paper, it's nice to see it presented though, and to hear the perspective of someone who is running that workshop. So thanks for that. I just want to ask you a couple of questions about, I found it interesting there where you presented the data on that there seemed to be less urgency on alignment or standardization of the competencies than other things. I found that kind of quite interesting, and I wasn't expecting it, to be honest. And I was wondering, why, do you have any idea why so? Is it because in reality, APRTs can be in extraordinarily varied roles? I mean, was that the reason, do you think, or?
I think there may be two flow, Michelle. I think what you just said that it may be one of the reasons. I think the other piece, I would say that, the competencies, I think maybe I would say for most of the service users, they're using that as a first step to standardize. So I think that's why you can't relate it. People find it, a bit easier to standardize. So when the thing's been done, I think that's why they feel like that, maybe the aspect need to be standardized, maybe less urgent because, there are a lot of work being done already. So I think that would be the two flow, kind of the cause and effect relationship between that.
And do you think that there's, yeah, following on from that, do you think there's an issue about, because, okay, we're talking about global radiotherapy practice, and we know even on, you know, undergraduate or entry level education is so different from one region to another. Do you foresee that that has an impact on competencies in advanced practice? I mean, I know a lot of advanced practitioners obviously have additional education, and then that's probably another day's work to talk about that. But, you know, do you foresee that that could have an issue on standardization of competencies as well?
I would say that the issue would come in would be the standardizations about the scope of practice and the
Yeah.
level of autonomy.
Mm-hmm.
Because I think, Michelle, I think as you mentioned about the education radiation therapist,
Mm-hmm.
I think one thing that we are very familiar with is the training and competency. So,
Mm-hmm.
I think that is kind of fully embedded in everything that we do as a radiation therapist. So I think that's why I feel like that for the competency concept, I think for APRT colleagues, they're able to utilize about what we have as a kind of the education philosophy within radiation therapies in the undergrad settings, and they're able to move into the advanced practice settings. So I think for the framework as such, I think will be okay for us to have a framework to standardize. But yeah, about the scope and the level of autonomy, I think that will be the difficult issues that we, as Robbie mentioned about, different
Mm-hmm.
healthcare providers, they will have
Yeah.
different policy within the countries. I think that will be the aspect I think that will be I would not say challenges, I would say the opportunity for us to work on.
Yeah, and Robbie, if I could bring you back in to the conversation for my next question, which is when Yat was presenting about the funding of positions, of course. I mean, for us in Ireland, that has been a massive barrier as to why we have not successfully had an APRT role as yet, which a lot of people find extremely surprising when we say that. And it's because of a funding issue. And you know, our APRT roles, I suppose, in this jurisdiction would have to be government funded. And like that piece about convincing, I mean, you know, it's one thing to convince whatever the administration of your hospital that this is a worthwhile endeavor. But for maybe I'll go to Robbie first and then back to Yas. But I mean, what about the bigger picture where you actually, you know, have to, you know, go to decision makers at maybe at state level in the United States, I don't know, or in a small country like Ireland, which is, you know, probably smaller than most states in the USA, you know, it will be at a national government level. I mean, I don't know. Have you any thoughts about that, Robbie?
A little bit. I think we just need to look at the standard of how therapy is at a base level and start realizing that we can't continue to do the same things that we used to do. The ASRT just released their national survey, and it showed that it has been an increase in unfilled positions, and it's up to like 13% vacancy rate, and it's gone up continually since 2014. So that's just showing that we are relying on therapists to basically all this technology that continues to change and update and advance. There is no level of growth there.
Yeah.
It's basically the therapists they're being forced to adopt the new technologies, the new treatments, the new everything, and it's just a part of their job. And I think it's finally gotten to that point where therapists are kind of done wanting to be that person that knows everything or is the go-to person, because it's an added level of stress, responsibility, risk, and there is kind of like what I said, there's no compensation for that. And I think the advanced practice role, like finding where those points are that in your clinic or in your country that's needed, and if you pay your therapist a little bit more, you're then providing opportunities for growth that we really don't have in our field. But you're providing it, and then you're giving them a little bit more compensation to make it worth the knowledge, the effort. And I think that's going to then give people more abilities to want to learn more. So I think pitching it in a way that's getting everyone to understand that we can't just keep doing it the same way. We have to change and we have to grow.
Yeah.
And that's going to start at an administrative level, and then just understanding like like if you have to continue to pay new hires and have to continue to do onboarding process, like in the long run, you're losing money. And you're also losing good therapists. So it's just that change of thinking that you have to have, and maybe government funding or something, but it's that first initial step to get people to think differently is very challenging.
Yeah. We could have a whole session on change management. Who knows quite a lot about that? I don't know, Yat, what are your thoughts about that, the funding of posts? And
yeah, Michelle, I think you're right, and I think that's something that actually I would say I changed my way of thinking when actually Nicole and I prepared a special issues for tipsRO, and don't want to play around the word. I think more likely the conclusion will come in, we want to focus on about, are we focusing advanced practice in the past tense, or we want to look at about the future, about advancing practice. And so for I doing the same because they still pay more for my salary. For the radiation medicine program at Princess Margaret Cancer Center, at the moment we have 7, advanced practice radiation therapists. We have the kind of the ambitions to grow the team, and to be even bigger. But with that, bear in mind that we always call advanced practice radiation therapists, they are change champions. So their role is actually established, about the buy-in, about the task shifting, as Robbie presented. But as long as they done that part, they're going to move on. So, for example, that as Robbie saying that, if the buy-in is actually, have radiation therapist-led organ risk contouring or target volume contouring, when they set up the framework of the training and educations, have a kind of the safe and comprehensive training framework for our radiation therapists to do that task, they will move on to the next task, so then we're able to actually advocate, the positions of the advancing practice component of these positions. So we're able to secure the funding to say that, we're not saying that, they're going to stay put and doing the same thing. Actually, they are carry on, focusing about the agile and continuous changing aspect of the role. I think that we got more success of secure funding from the stakeholder in that sense.
Yeah, thanks. That's both very interesting perspectives on it, and something that we're grappling with a lot here at the moment. And kind of leading on from that, then, Yat, I'll maybe start with you this time about, and Robbie alluded to it, about the ASRT report, which, let's be honest, is probably mirrored in most countries in the world about the retention of staff. And do you feel that the APRT role has, and this is again something that we've grappled a lot with in trying to convince the government that this is actually an APRT grade is going to help us massively in terms of retaining staff, because now there will be a career, a proper career pathway. I mean, I don't know, Yat, what's your thoughts about that?
Yeah, I think definitely. I think that will be something. It'll be great as a kind of the retention a strategy about how we're able to not just retain. Actually, it's about recruit colleagues into the profession as well. But I think some of the findings, Michelle, that I think Robbie mentioned about the ASRT survey, and then I think we got the kind of the opportunity to work with the ASRT colleagues recently on the advanced practice in the United States as well. And one thing that we do see for the countries that actually, for example, for UK and Canada, they managed to excel, the advanced practice pathway, that they have a very strong standardizations about the education requirement for the undergraduate level. And compared to some other countries, I think Michelle, as you say that for Ireland, that you guys are so strong for that as well. So I think that will be, I would say that it will be a very solid base for us to look at about the career progression pathway is actually consolidate our undergraduate education requirement first as an entry level as a radiation therapist. When the base got set, I think that we're able to build on top of it for advanced practice, I would say.
Yeah. Robbie, do you think that it would be very if you think about graduate entry radiation therapists who are joining you at work, do you feel that if there was a very defined, and obviously, you said there's just 2 APRTs in the US and you're one of them, but like if there was a very defined APRT pathway, regardless of state or institution or whatever you were at, would you feel that that would be highly, that would be a good motivator for people entering the profession?
I do. I think it would just have to be done the right way, because obviously part of being that advanced practice is having that expert knowledge, like you guys have basically published and that I've used and everything that I've said is you have to have that expert knowledge, and coming out straight from school, you don't have that expert knowledge. You have your textbook knowledge, and then you get into the real world and learn how to actually apply all of those things that you've learned. But I think if it's established correctly, and whether that be a dedicated course or a dedicated training system or something that has to be very standardized, and it could be master's level, it could just be something that you've created, and that doesn't have to be a master's level. You have to provide an opportunity for people to want to be able to do it and make it accessible in a way that's going to work for them. Where a master's program might be too cumbersome, but others might find that perfect for what they're wanting. I think it also matters about what role and how it's going to be, whether if that's creating a position like what we have, where we have that gray zone with contouring. That's kind of a pathway that there's no one doing it. So that's why I feel like that's a good place to start, because you're not impeding on any other roles. You don't have to worry about competition. You don't have to worry about people getting upset. But there's a turn to that, because like some clinics might need that.
Yeah.
So it's hard to establish, but I do think it is something that if you're showing the pathway and you're showing the need for it, getting people to jump on board is the next step. But I do think that would help with retention, because you're showing the field that there is an opportunity for growth.
Yeah, and I guess it comes back to, you know, what you had done in the workshop with colleagues about, you know, the different roles. And I guess it depends on how you're defining, all the way back to how you're defining advanced practice. And if you're going with the kind of traditional pillars of advanced practice at ESTRO, we'd always, you know, where people obviously are involved in research and leadership and dissemination and things, we, you know, as you know, in the ESTRO first paper, we will always say that master's level education is probably the way to go, because so that people can meet those pillars, because it's quite difficult to be involved in research and dissemination if you haven't been at you know, been at that level. So look, guys, thank you so much. Our time has run out, but thank you so much for joining today, and for the really great discussion. And again, to those listening, we have to apologise profusely for our complete and utter technology fail today, and we hope that you have enjoyed listening to us, and hopefully I've put the questions to our speakers that were also on your mind. And with that, I'll say thanks, Robbie, thanks, Yat, for joining us, and thanks everyone who's listening remotely now, and we hope you'll join us again the next time for our next webinar. Bye bye.